Welcome back, everyone. Ready to take another deep dive with us?
Always.
Today we're tackling a topic that can be, well, a little tricky, even for seasoned coders.
Yeah. Pathology coding.
Pathology coding. It's got its own set of rules and nuances, and we're going to untangle them all today with the help of our trusty guide, the Absolute Medical Coding Institute's Facts to Remember.
The FTRs.
Yep. They're like our cheat sheet packed with expert insights, especially if you're prepping for those certification exams. And of course, we've got the Medical Coding Guidelines Manual linked in the description for even more deep dive fun.
Right, so let's jump right in.
Okay, so let's start with something that seems pretty straightforward at first glance. But as we all know, there can be some hidden traps lurking beneath the surface.
Oh, what are we thinking?
Organ disease panels. They seem simple enough, but...
Yeah, but they can definitely be tricky.
Exactly. So what are some of the things coders really need to watch out for when coding these panels?
The first thing you got to remember is that just because there's a panel of tests doesn't mean every single test in that panel was actually performed. So before you even think about coding, you got to check were all the tests in the panel actually done.
Oh, good point. If not, you can't code the whole panel, right?
Right. You got it.
Okay.
Right?
So it's not just about recognizing the panel, it's about verifying what was actually done. That makes sense. But what about those times when a doctor orders a panel, but then tacks on a few extra tests that aren't part of that standard panel? How do we code those?
Well, you got to code those extra tests separately.
Separately, got it.
Yeah, it's about representing every single service that was provided, not just lumping everything together.
Right, accurate representation. Okay, so we're separating out those extras, but sometimes it's not just about extra tests, it's about overlapping tests.
Overlapping.
Yeah. What if we have, let's say, a comprehensive metabolic panel, it's got a whole bunch of tests, and then the doctor also orders a separate lipid panel. And some of those tests are already included in that metabolic panel.
Yeah.
What then?
Yeah, that's where you got to be really, really careful not to double dip, you know?
Double dipping, yeah.
In those cases, you code for the bigger panel, the comprehensive metabolic panel in your example, and then you only code the unique tests from that smaller panel that aren't already included in the bigger one.
So it's like finding the most efficient and accurate way to represent everything without overcoding or undercoding. Accuracy is our shield, right?
Exactly.
Speaking of efficiency, what happens when a panel is ordered, but for some reason, not all the tests get done? Like maybe the lab couldn't run one of the tests, so there wasn't enough sample. I've seen that happen.
Happens all the time.
Yeah, and it feels like we need a way to, like, signal that the panel wasn't completed as originally intended.
You're telling me, well, that's where our good friend Modifier 52 comes in.
Modifier 52, okay.
It's like a little flag, you know, it's lets the insurer know, hey, we didn't do the whole thing here.
Okay, I see.
So you can adjust the code to show that the service was reduced, partially reduced.
That's a relief. Because without that modifier, it might look like we're trying to bill for something that wasn't actually done.
Exactly.
And we definitely don't want that. So let me just recap to make sure I've got this straight. When we're coding panels, we double check that all the tests were actually performed. We code any extra tests separately. And if the panel is incomplete, modifier 52 is our friend. Got it.
Nailed it.
This level of detail, I think, really protects us from potential audits down the road. And it ensures that we're getting paid accurately for our work. Now, all this panel talk, it kind of makes me think about another area where coders can trip up.
Oh, let's hear it. What's on your mind?
Drug testing.
Oh, yeah.
And specifically, you know, those situations where a doctor suspects drug use, but they don't know which specific drug to test for.
Tricky.
So we're coding for a drug test without knowing what we're looking for. That's tough.
It is. And that's where knowing the difference between presumptive and definitive screening really comes in handy.
Okay, presumptive versus definitive.
Presumptive screening, you're basically casting a wide net, just trying to see if there are any potential substances present.
So not pinpointing a specific drug, but more like a general screening to see if there's any evidence of drug use.
Exactly.
Like a detective gathering clues at a crime scene.
Right. Perfect analogy. And then if that initial screening comes back positive, then you move on to definitive screening, which actually identifies the specific drug or drug class.
Okay, so we're zooming in on the culprit, so to speak.
Exactly.
This is making more sense now.
Yeah.
But how do we actually code for these different types of screening?
Well, the codes really depend on the method that's used for the test. So there are specific codes for like direct, optical, instrumented, and non-instrumented methods.
Each method has its own code, so we'll need to check the CPT manual to make sure we're using the right one.
Always a good idea.
But I'm guessing documentation is super critical here too, right?
Oh, absolutely. The physician has to clearly document their suspicion of drug use. You can't just use those codes willy-nilly.
So if a patient comes in, say, with slurred speech and dilated pupils, and the doctor suspects drug use, that suspicion has to be documented in the patient's record to support the use of that presumptive screening code.
You got it.
That makes sense. I bet that's where some coders get tripped up.
It happens. Documentation is key. It's all about painting a clear picture for the insurer and avoiding those claim denials.
Right, and ensuring we get paid for our hard work.
Right.
Okay, so let's say that initial screening comes back positive. How do we move from that general suspicion to a specific diagnosis?
Well, once that presumptive screening identifies a potential drug class,
Like opiates or something like that.
right, then the next step would be a definitive test to actually confirm the presence of that specific drug or drug class.
And that definitive test would have its own code, depending on the method used. It's all connected. We're going from suspicion to confirmation, right?
Connecting the dots.
Exactly. That brings us to another tricky situation. What happens when you're trying to code for a specific drug that's not even listed in the CPT manual? I mean, new drugs are coming out all the time.
All the time. And that's why it's so important to stay up to date. But luckily, for those situations where the drug isn't specifically listed, the CPT manual does have some wildcard codes.
Wildcard codes?
Yeah, like 8/375, 80377, and they're specifically for those non-listed drugs that are used in therapeutic assays or chemistry.
Oh, so there's a safety net.
There is.
But it sounds like staying updated on those new drug codes
Yeah.
and checking that CPT manual regularly, that's essential for anyone who deals with this stuff.
Absolutely. You got to stay on top of it because this field is constantly evolving. Can you imagine trying to code for a brand new designer drug that just hit the streets?
Yeah, talk about a challenge. You need to be a detective and a code breaker. But speaking of challenges, I want to shift gears for a minute and talk about another type of consultation that can be really tricky, surgical pathology.
Surgical path.
Yeah. It's such a unique setting, and I've always wondered how coders handle those real-time insights that pathologists provide during surgery.
It's definitely unique.
It sounds pretty intense. So are we talking about a situation where the pathologist is actually looking at slides and records while the surgery is happening?
Yeah, that's often the case. It's very much a real-time collaboration, sometimes with high stakes.
Wow, that's incredible. But it's important to remember that this is different from a clinical consultation, right? Where the pathologist might be reviewing a case before or after the surgery.
Totally different. With the surgical path consult, it's all about giving those immediate insights to guide those split-second decisions happening in the OR.
Right, so it's not just a quick phone call. It's active engagement.
Active.
Even if they're not physically in the room.
Right.
Okay.
Yeah.
So just like with those clinical consultations we talked about, those 3 R's apply here too.
Right.
Right? Request, render, report.
Absolutely. Still got to have a formal request from the surgeon. The pathologist uses their expertise to render a professional judgment, and then everything is documented.
You know, a lot of people think the patient has to be physically present for a surgical pathology consultation, but that's not always true.
Not at all. I mean, with all the technology we have now, the pathologist can review the case remotely.
Telemedicine for pathology.
Exactly. They might be looking at digital slides, images, or even having those tissue samples sent over from the OR.
That's wild.
It is, and it really highlights how critical accurate documentation is, because we got to be able to show the insurer that the pathologist did actually provide real-time consultation services, even if they weren't physically there in the room.
Makes sense. So we need to document the request, the findings, the time spent, any communication that took place, paint a complete picture.
Exactly.
And I think it's so important to emphasize just how valuable the pathologist's expertise is in these situations.
Oh, for sure.
They're like medical detectives, helping the surgeon piece together the clues and make the best possible decisions for the patient.
Love that analogy.
And it just highlights how important accurate coding is in this whole context.
Yeah.
We've got to capture the complexity of those consultations.
Yes.
Wow, this has been eye-opening. We've gone from those organ disease panels to drug testing and now surgical pathology consultations. It's amazing how much goes on behind the scenes to make sure patients are getting the right diagnoses and treatment. But I feel like we've just scratched the surface.
Oh, we're just getting started. Get ready to dive even deeper into surgical path coding. We're going to explore the fascinating world of what's visible to the naked eye versus what's revealed under a microscope.
It's where art meets science, right?
Exactly, it really is. Think about a surgical pathology case like a landscape painting.
A landscape painting. Okay.
So yeah, that initial gross examination where the pathologist's just looking at the specimen with their naked eye, that's like an artist sketching out the basic outline of that landscape, just getting a feel for the big picture, the overall composition.
The first impression.
Yeah, before they start adding all the detail.
Right, the broad strokes.
Exactly. But then, just like that artist would pick up their finer brushes to add all those intricate details, the pathologist turns to the microscope to look at that cellular world, all those little things hitting within the tissue. That's where the real detective work begins.
So the gross examination, that gives us the context, the overview, and then the microscopic examination, that zooms in on those little clues. I like that. But I bet all of this impacts how we code these procedures, right?
Absolutely. Just like an artist uses different tools for different levels of detail, pathology coding has different codes that reflect how complex the exam is.
So if a pathologist only does a gross examination, there's a specific code for that.
Yep. Code 88300, that's your foundation, your starting point.
8300, got it.
But then as soon as you bring in the microscope, things get a little more interesting.
Because now we're adding that whole other level, going beyond what we can see with the naked eye.
Exactly. Those higher level codes, the 88302 through 88309, those come into play when there's microscopic examination involved. And which code you pick depends on just how complex that examination is.
And I imagine the documentation has to be really specific to support using those higher level codes. We got to prove what was done.
Oh, absolutely. The pathologist's documentation, it needs to be meticulous, like how many blocks they examined, what stains were used, the complexity of the tissue itself. It's all about painting a picture for the insurer.
Showing our work.
Exactly.
Okay, so it's not just about looking at it under a microscope. It's the analysis, the interpretation, the depth. But are there other services that a pathologist might perform during a surgical path case that we'd also need to code for?
Oh, yeah, for sure. One of the most common ones is frozen section analysis.
Frozen section analysis.
Where they take a small piece of tissue, freeze it, slice it really thin, and then examine it under a microscope, all right there during surgery.
Wait, so there's like a mini lab in the OR?
Pretty much. It lets the surgeon get real-time information about the tissue, which can be really important for guiding decisions during the surgery.
Oh, wow, that's so cool. So it's like having a pathologist consultant right there on the spot. No wonder it needs its own set of codes.
You got it. Frozen section analysis has its own unique codes, and it's important to capture those accurately.
Right, because it's a totally separate service.
Exactly.
This whole world of surgical path coding is so intricate. It's like we're weaving this tapestry, telling the story of what happened in the lab.
I like that. A tapestry of codes.
And how it impacted the patient's care.
Beautifully said. And speaking of stories, those surgical pathology consultations, they've got their own narratives, too.
Oh, yeah, the consultations. It's where the pathologist gets to be like a real-time consultant, helping the surgeon during the surgery. That's always fascinated me.
It is fascinating.
So we're talking about situations where the pathologist is looking at slides, reviewing records, all while the surgery is going on, right?
Exactly. And it's important to remember this is totally separate from those clinical consultations we talked about before.
Right, where they might be reviewing it before or after the surgery.
Exactly. Surgical path consultations, it's all about giving those immediate insights.
Right, real time.
To guide the surgeon, like right then and there.
So it's not just a quick check of the chart. It's really active involvement.
Active.
Even if they're not physically present in the OR.
Yep.
Okay. But just like with those other consultations, the 3 R's still apply here, right?
Yeah.
Request, render, report.
Absolutely. There has to be a formal request from that surgeon. The pathologist provides their professional judgment, and then it's all documented in a report.
Those 3 R's.
Yeah.
They're like our guiding stars.
But you mentioned earlier that the patient doesn't actually have to be there in the room for a surgical path consult. How does that work?
Well, thanks to technology, the pathologist can review everything remotely.
Oh, cool.
Yeah, they might be looking at digital slides, images, or even having those tissue samples sent right over from the OR. It's like telemedicine, but for pathology.
Exactly. And that's why accurate documentation is more important than ever. We got to show the insurer that the pathologist provided those real-time services, even if they weren't physically there.
Makes sense.
Yeah.
So we need to document the request, the findings, the time spent, all the everything.
Everything.
And, it's important to emphasize just how critical that pathologist's expertise is, especially in these situations.
No, absolutely.
It's like they're medical detectives, helping the surgeon make the best decisions for the patient.
I love that. Like Sherlock Holmes in the OR.
Right. And that's why accurate coding is so important.
It is.
We got to make sure we capture the complexity of those consultations and that the pathologists are being fairly compensated for all that expertise.
Couldn't agree more.
This has been incredible. We've gone from the basics of that gross examination to all those microscopic details of frozen sections, and now the real-time intensity of surgical path consultations. It's amazing how much happens behind the scenes to make sure patients get the best possible care.
It really is. And as we continue our deep dive, we're going to explore how these coding principles apply to even more specialized areas of pathology. So buckle up. It's going to get even more interesting.
Wow, we've really covered a lot of ground today. We talked about those organ disease panels, the ins and outs of drug screening, and even got a glimpse into the fast-paced world of surgical pathology consultations.
It's amazing how much goes on in the lab.
Really is.
Yeah.
And through it all, those codes, they're like puzzle pieces, each one telling a part of the story.
And when you put them all together,
You get the full picture of the patient's care. It's been fascinating to see how important those details are when it comes to selecting the right code.
absolutely. And how crucial it is to, keep learning and staying updated on those coding guidelines.
Because things are changing all the time, right?
All the time, medicine's always evolving, new treatments, new technology.
The codes. So we need to evolve with it.
We do.
These facts to remember from the Absolute Medical Coding Institute, these FTRs, they've been incredibly helpful in breaking down all this complex stuff.
I love them.
They're like cheat sheets, but with expert insights.
It's like having a tutoring mentor, whispering in your ear.
Right. Guiding you through those tricky situations. And of course, we've got that medical coding guidelines manual linked below.
Yes, that's a must-have.
It's a must-have for any coder who really wants to, master the art and science of pathology coding.
It's an art and a science, that's for sure.
So as we wrap up this deep dive, what's the one big takeaway you want our listeners to walk away with today?
I think the most important thing is to never lose that curiosity, that thirst for knowledge. Because this field, it's always changing.
We can't just sit back and relax.
No, we got to keep learning, keep those skills sharp.
So never stop asking questions, challenging yourself, and, exploring this fascinating world of pathology.
Exactly. Because accurate coding, it really does make a difference in patient care.
That's a great point to end on. To all our listeners out there, keep those coding manuals close, stay curious, and we'll see you next time for another deep dive into the ever-evolving world of medical coding.